Hi, everybody. Thank you for taking the time out of your busy lives to take a look at our presentation here. Um, a lot of you may know me. My name's Dean Bryan. I'm the clinic director and owner of Bryan Vision Associates. A few years back, I had to discontinue seeing patients because of being diagnosed with Parkinson's disease, and it basically began to limit my ability to do exams effectively and safely. So I've taken on the clinic director role, and I'm still checking in on you guys all the time. I'm helping to review scans and look at images that we collect and put my input in when the other doctors ask for it. But I do appreciate you guys taking a look at this presentation. We're going to do several of these as we go through the months. At least I hope we can keep up with that. For today's talk, I wanted to, for this first talk, in other words, I want to discuss digital retinal imaging. This area has always fascinated me because I'm a very visual person, and that's how things make sense to me. And I hope this presentation will kind of convey that idea to all of you and give you a new understanding, quite frankly, of the eye and how it works. So without further ado, let's go ahead and get into it. So I think before we talk about the imaging itself, we should discuss eye anatomy a little bit and kind of brush up on how things work. This is a cross-section of a human eye, and on the front, right here, is the clear window on the front of the eye, and that's called the cornea. There's a fluid-filled chamber behind it, and then there's the iris. So when you look at somebody's eye, you'll see the colored part of their eye. Up in front of that colored part of their eye is the cornea, the window on the front. The cornea is continuous with where the white of the eye starts. The reason why the eye is white here is because the collagen layers are laid down haphazardly, and it makes it an opaque white coloration. The cornea has the same fibers, but basically they're orientated in a very specific way to give that tissue an optical clarity to it. So it's kind of interesting how that's all designed, if you will. And then the fluid-filled chamber, like I said, here, and then the person's pupil, and then we've got a lens here, the crystalline lens, and that's the job of that structure is to focus the light. Say we're looking far away, and then we go to look up close, that lens will change shape to bring the focus point to where we can read. And then we look far away, it changes shape again, and then we can see far away. That's the tissue that cataracts develop in as we age, and the lens hardens as we age and we lose our ability to focus. Then going back into the middle of the eye, we enter into the posterior chamber, which is filled with a jelly-like substance called the vitreous. Now in a young person, the vitreous is like jello. It's very thick in consistency, and it's inflated, and it fills up the volume of the eye quite nicely. As we age, though, the jelly-like vitreous becomes more fluid-like. Pockets of it liquefy, it starts to strand, and it starts to pull away from the back of the eye a little bit. And that's a normal process. We'll talk about that, and I'll show you some images that kind of show you what that process is like. And then we come to the back wall of the eye, and that's where the retina is, this yellow layer that we see on the back wall of the eye here. The area of the retina that's responsible for the dead center of the vision is the macula, and in the center of the macula is this little pit right here. That pit is called the fovea. If light focuses right on that spot, you will have crystal clear vision, unless something else is going on in front of this. But you'll have crystal clear vision, distance or up close, if the light focuses right where it should and there's no disease going on in the retina that would impair it. Now, the retinal fibers all gather and form the optic nerve, and that goes out the back of the eye and goes to the brain where the vision is processed. And that's obviously an important structure, and you'll be able to see that here in a minute. So light comes in, and it goes through the pupil, through the lens, and we want to focus right on that spot. If your nearsighted light comes in and it focuses ahead of that spot, and then it defocuses and your vision's blurry. If your far-sighted light comes in and will focus if you traced it back to behind the eye. So things are out of focus unless you can focus enough with your lens to bring it into focus. So I don't mean to digress and get off the subject, but I just want to give you guys a clear understanding of how the eye is designed and how it works, and just some of the basics there for you to grasp onto. All right, let's go forward. So here we are looking at a photograph basically of the human retina. And what we're seeing is, or the way we're seeing this is as if we're looking through the person's pupil directly at the back wall of the eye. So we have a frontal view, if you will, of the retina. This is the optic nerve, and this is the macula with the fovea in the dead center of it. So that's what it looks like, and that's basically what we see when we look in with our instruments and we're trying to assess the quality of these tissues. The thing I'd point out about this slide, though, or this picture, is the fact of how vascularized this tissue is. And this is why we have eye exams, because the eye is the one organ on the body that we can see blood vessels live and in action. Okay? There are cases where we find little cholesterol plaques or little emboli that are thrown from a heart valve or something, or from somewhere else, that will lodge in one of these bifurcations and block the flow of blood downstream. That's called a branch retinal artery occlusion. Those things happen because maybe the person has a buildup of plaque in their carotids, and that's due to elevated cholesterol. So we can pick up things like that. Any kind of blood related type of disease process. Diabetes is an excellent example. The eye is one of the first places that diabetes is picked up. Now, if our retina if our kidney had an easy access door to it, we'd probably be going in for yearly kidney exams too. So your eye exam, the thing you have to think about is your eye exam is not just about, getting glasses, contacts, what have you. That's certainly a big part of it, to, be able to see as clearly as you can. But the other part is to take a look at your eye health, because it represents quite literally the rest of your body and the health that is happening there as well. So how do we look into the eye? Well, one of the tools that we use is called a direct ophthalmoscope. It's handheld, it's portable, it has pretty good magnification, but it's got a very small field of view. I'll show you what I mean by that in a minute. It's monocular, meaning only one of my eyes can get into your eyes through this scope. So I don't have depth perception when I look in. You have to be face to face with the patient. I mean, very, very close. And in this day and age of COVID, that's not really all that desirable. Can be used through an undilated pupil though, and it's still in use today. It has its place clinically for a few things, but there's better tools now that we use to assess the retina for sure. Now your PCP may still use this particular tool to look at your eyes very briefly. They are just looking to make sure that they can see maybe an optic nerve in the back of each eye and maybe the macula, and if they can get a view or not. But that's what they're doing. That's what they're using. So what kind of view do you get? Well, with the direct ophthalmoscope, you get this much area at a time. So you can imagine trying to cover all this territory with a direct ophthalmoscope. It would take a lot of time. And if the patient's looking around a little bit and you're struggling getting into their pupil, it becomes a real chore to get a good view and to feel comfortable saying to the patient, yeah, it looks like everything's clear and normal, because you may have missed something very easily. So the next tool that we draw from, or that we use, is what's called a binocular indirect ophthalmoscope. So it's binocular, which is an advantage because you can see depth and some things in the retina. To be diagnosed, you need to know if there's a thickening of the tissue or something along those lines. It's got a much wider field of view versus an indirect scope. It's binocular, like we said, and it maintains it as the gold standard tool for viewing the retina to this day. Your retinal specialists, in particular, know these instruments inside and out, and they depend very heavily on the BIO to do their retinal exams because they want to have a live look. Now, the disadvantage is it takes a lot of skill to operate these. And we use them here too. When we dilate our patients, we'll use the BIO and we'll take a look at the retina under dilated conditions. And it's very, very good tool. But it also creates a situation where the retina image that you see is viewed upside down and it's reversed. So if I see a lesion in the back of an eye and I'm thinking to myself, okay, this is reversed and it's upside down, it leads to a lot of mental gymnastics trying to chart where that lesion is. And with the headset, you also use a lens. You hold it in front of the patient's eye, and now you can see how much area that a BIO covers. So quite a bit more than the direct ophthalmoscope. So it's considered the gold standard tool for retinal evaluation today. It has a steep learning curve. Unlike digital imaging tools, the BIO provides a live look, and that's why I do highly doubt this tool will become obsolete, as many retinal conditions require a live dynamic look to assess fully. Okay. All right. Now, I don't know how many of you guys remember this, but we had this instrument in the office. I think we got it in 2004. This thing came out in 1999. The Optos Panoramic 2 came to market after years of research and development. The owner of the company, the president of the company, he made it his mission to design an instrument that could image the retina in the back of the eye, as much of the retina as you possibly could get, because his son had suffered at a very early age a spontaneous retinal detachment, and he saw how hard it was for the doctors at the time to be able to diagnose that. And he thought to himself, wouldn't it be great to have an instrument that could capture most of the retina in one shot? So that's what came out of those early thoughts of his, and we brought it into the office in 2004. And I can testify it has literally aided in the preservation of vision for many of our patients. It was a big thing. It took up a big footprint and sounded like an airplane taking off when you turned it on. So what kind of view do you get with the Optos? This is what you get. It's huge. You see most of the retina. You can see interrelationships between different sections of the retina. You get a very full understanding of the person's eye health in a very quick amount of time. So optic nerve, once again, macula, once again, you can zoom in on these. You can put different filters on the image and differentiate lesions that way. There's lots of things you can do with this, but the field of view is just incredible. Now, if you compare that to the typical BIO field of view, you can see the difference now. So one lens with the BIO, you see this much. So you literally have to keep doing this all over and try to scan the entire retina as best you can. So this revolutionized imaging in our profession for sure. And the neat thing is this company made it their mission to get this instrument out not only to the retinal guys, but also to your local primary care eye care provider like us. And it really aided our diagnostic capabilities and made our referrals so much better. Now today, of course, we don't have that that same instrument, the P200. We now have the Daytona, which in and of itself is getting aged, but it is a fine piece of instrumentation, and it's several steps above the Optos P200 because you actually get a little wider field of view with it, and it's much easier for the patient to get their eye into and to get a good image. And it also gives what's called this autofluorescence scan, which is a unique scan and is useful in macular degeneration cases. So it's kind of a neat add-on that came with it. Plus the software that's tied with this thing is just fantastic. So it's a big upgrade, but it's probably due to be changed out sometime down the road here. So here's some images that we've taken in our practice. We've got tons of them. I thought I'd pick out a few for you guys. This one, what you're seeing here, the retina itself looks pretty good. This is just an artifact from the flash of light that went off. But in the macula, and the fovea is sitting right in here someplace, there's a bunch of little white dots, and they're kind of soft white dots. They're not hard ones. This is a hard one here. These guys are soft. This is what's called drusen, and drusen is an early indicator of macular degeneration. So this person has an early, actually I'd say it's more early to moderate macular degeneration development, and when they're soft, that's not a good sign. Kind of suggests that this is going to evolve a little more quicker, and it's going to be more destructive. Now, what's going on in here? This is a diabetic eye. You can see there's a hemorrhage here. If you look around, you'll see little dot hemorrhages and things. But you may be wondering, what are all these? Looks like cigarette burns on the retina. Why would that be there? This is treatment. This is called pan-retinal photocoagulation. and it's an effort to decrease the oxygen demand of the retina by zapping good tissue out in the periphery to preserve the center here where your center vision is in the macula. So we zap, or the surgeon zaps, the peripheral retina, which is responsible for your peripheral vision, to save the central vision. Because in diabetics, the oxygen demand of the retina is compromised because the blood flow in diabetics is compromised itself, and so we have to decrease that oxygen load. So this person at night is going to have a very difficult time with night vision because that peripheral retina has pretty much been zapped. But once again, we're saving the central vision, and this treatment is still utilized today. So that's a patient that we had in the clinic. And another one, this one. I had 3 of these in 1 week. I couldn't believe it, but this is a retinal detachment. So the retina, when I showed you the eye anatomy cartoon or drawing, is that yellow layer on the back wall of the eye. It's like a wallpaper. It's held in place. It's not physically attached necessarily to the back wall of the eye. And so if, for example, a tear occurs in the retina and fluid from the vitreous cavity here in front gets into that tear, it can get underneath the retina and the wallpaper can literally come peeling off. And you can see the leading edge is right here. This is an immediate referral to a retinal specialist to get this tacked back down, because once this fluid gets through the macula and the fovea and the retina detaches, the chance of recapturing good vision and regaining good vision is quite limited. So we're always looking to see, is the macula still on? And if it's still on, it's more of an emergency than if this has gone through that macular zone already. Still an emergent situation, but not as urgent as this case was. Okay. So what if we could get a cross-section view of the retina? You know, we're talking about a top-down view or frontal view this whole time, and the Optos is amazing and it's done a fantastic job for us. But what if we could take the retina and cut through it and turn it on its side and see the layers? Well, we can, and we've got the instrument to do it. It's called an OCT, an optical coherence tomography. Now, I'm not going to go through all this. This is some information from Wikipedia, and kind of explains that basically this image is captured by light. It's captured by non-coherent light and interference, and how the light interacts with different densities of the tissue to create an image that shows the layers of the retina. So there's 12 layers to the retina, and you can pick all 12 out with this OCT scan. Now, totally amazing. This is the most important technological tool for examining the retina ever created. It has literally saved hundreds of thousands of people's vision, for sure, probably more. So here's my eye with the OCT. And this cut here is the cut right through the macula, right through the fovea where this red line is. So literally, we've cut through the tissue and we're seeing it on the side like this. This is the optic nerve going back. And then this is the little pit where the fovea is, and this is the area that's responsible for your sharpest, clearest vision. And it does several more cuts. It actually does, let's see, 7 cuts through here, high resolution cuts. And it also maps out the thickness. Now you can start measuring actual thickness of the tissue. And when it's on its side like this, you can start picking up things happening in the retina that from a frontal or top-down view of the optos, you don't see. So this is just an amazing device. Now here is that patient that has the soft little drusen deposits. Now you can see them. They're right here, these little bumps, right underneath the fovea. Person's probably still seeing 20/25, 20/30 at best, but eventually this is going to come to become a problem, basically. And macular degeneration is a progressive disease, although ocular nutrition and certain interventions, when needed, can help preserve the vision for as long as possible. So, in any case, that gives you an idea of what little drusen look like on the side through a cross section. And it's also telling us here, if we mapped out the thickness of this tissue all the way around, that the center is thicker than it should be because of these drusen deposits. And also shows up on this map here too. Now this I threw up here because I just wanted to show you we can reverse the shading here so you can see the layers a little more distinctly. This happens to be my son's eye, a nice young healthy retina with a good foveal pit, and the layering is very definitive and clearly distinguishable. Beautiful. We can also take 3D chunks of tissue and look at it and analyze it. So this is a 3D chunk of tissue that has the optic nerve in the center on that patient. So kind of cool. And then we can put it in more of a color format so you can see the layers with color too. Most retinal specialists, and what we'll use in the clinic here, is more the grayscale, because it's just easier to see. There's a lot of noise in these pictures. What I wanted to show by this picture is you'll see that there is a little something here that's hooked. This is where the fovea was, but it's being pulled up and cavities are forming, fluid-filled cavities are forming, because the vitreous is pulling away from the back wall of the eye, but it's strongly adhered to the fovea in this person, and so it's creating a swelling of tissue. And that can create a drop in vision to, say, 20/25, 20/30, 20/40. And at some point, if that keeps pulling and won't release, it could form a through and through hole in the retina, right in the dead center of the vision, a macular hole. So there's ways that this tension can be released if we need to get that patient in to have that done. So this is how we monitor it, is with this OCT tool. And this is an eye wellness OCT scan. I'm going to talk about that here at the end of the presentation. But the eye wellness is a neat thing that we have on our OCT that gives us just a kind of an overall summary of retinal health. So we see the layers. It gives us an idea about glaucoma, and also gives us an idea about just retinal vascular health as well. I'm just all over the place with the laser pointer, I'm sorry. And then finally, this kind of sums up the digital retinal imaging that we offer at our clinic. We've got the Optos image that we've tried to keep at a very reasonable price. We charge $35 currently. That's probably going to be going up a little bit. in the near term, but just to give you perspective, in 2004 we started the pricing at $29, so we really haven't gone very far with this. We've tried to keep the cost very manageable. It's a 200-degree digital image of the retina from a top-down perspective, recommended for every patient at every comprehensive vision exam. Doesn't replace dilation. If the patient's having symptoms of, retinal compromise, we'll advise to do both a dilation and a Optos image too. The OptoView Eye Wellness Scan, we charge $19 for that. And that's the generalized scan that gives an assessment of glaucoma, macular degeneration, and retinal vascular health. Recommended periodically for those patients with a family history of glaucoma and or macular degeneration. It's recommended yearly for those patients with comorbidities of heart disease, high blood pressure, elevated cholesterol, and or diabetes, because it's the one way that we can really analyze what's going on with the retinal vasculature. That cross section is very important in looking at those issues. And then we do a package. We do an Optos and a wellness scan together for $45 if taken at the same visit. So it's really the Optos, and for $10 more we throw in the wellness scan. So I encourage those of you who do have heart disease, high blood pressure, cholesterol issues, diabetes issues, I really, really advise that both of these imaging scans, if you will, be done at every visit, every yearly visit that you come in. And those of you who have a strong family history of macular degeneration and glaucoma, really important that maybe every few years that you get a wellness scan in addition to the Optos. All right. So that's all I have for you guys. If you have questions, any general questions regarding this presentation, please feel free to email me at the address that you see there. Now, it's important for you to know that I can't give you medical advice or provide a diagnosis via email. You have to be seen. But I'm happy to discuss any items covered in this presentation. And this has been a lot of fun for me because, like I say, I really miss the clinical side of the practice. So I appreciate you tuning in. Thank you so much for watching, and we'll hopefully see you down the road at another one of these. Thank you.